Thank you. And so I'll discuss these following topics in my presentation: MPN and thrombosis, and provide an outline of this, some details on pathogenesis, especially about JAK2 mutation without an overt myeloproliferative disease, risk stratification schemes that we tend to use, and a bit on prevention and treatment, and at the end, some distinctive syndromes. What I'm not going to do is to provide you with a complete review and an overview of how to think about and treat patients, because such reviews are, there are several good published reviews, and indeed one ongoing one in Blood. So the WHO classification from 2016 categorizes, in addition to our well-known previous categories of PV, polycythemia vera, essential thrombocythemia, myelofibrosis, but also lists prefibrotic myelofibrosis as a distinct category, and MPN unclassified. Incidence is about 1 in 100,000, so it's considered a relatively rare condition. And the median survival in ET patients is more or less normal to unaffected patients. 20 years median survival in polycythemia, and about 10 years in myelofibrosis. In terms of vascular risk, both arterial and venous vascular thrombosis are common. Microvascular syndromes are particularly common, especially in ET. Arterial thrombosis is more prevalent than venous. Mortality related to cardiovascular disease is about 1.5 deaths per 100 patient-person years. And the morbidity is high, with a high recurrence rate, with about 42% second event in about after 10 years of the first event, and that's despite being on anticoagulation treatment and secondary prophylaxis. About 35%, so about 1/3 of PV patients and about 1/5 of ET patients will have had prior thrombosis within 2 years of diagnosis. Unusual vascular syndromes are particularly interesting in MPN. Splanchnic venous thrombosis, about 40 to 50% of Budd-Chiari syndrome patients will have an underlying MPN leading to it. Cerebral venous thrombosis has also been identified as one of the risks in these patients, as well as pulmonary hypertension, especially in myelofibrosis. This is a graph by Hultkrantz in 2012, basically showing that with advancing age, the deep purple is elderly, the light blue is young. The survival reduces over time, but more interestingly, that from 1973 to 2006, survival across all age groups has improved, primarily because of improved cardiovascular risk assessment and treatment. So in terms of pathogenesis, some key questions that I thought might be of interest to this group. There's one mutation, but leading to several phenotypes. Different mutations have distinct effects. Mutational landscape goes beyond the 3 common driver genes, which are the JAK2 V617F, the CALR mutation, and the MIPL mutation. The fact that JAK2 V617F can be thrombogenic without a myeloproliferative phenotype, and the fact that there are unusual site thrombosis in this disease group. And underlying all of this is the fact that there is the genotype and the genetic clone abnormality, the stromal abnormalities leading to crosstalk between microenvironment and the clonally deranged cell, the vascular abnormalities dealing with the endothelial cell and the vascular flow circumstances, plasma protein abnormalities related to both clonal and stroma, and cellular abnormalities from the bone marrow produced cells. And this schematically connects it. The tumor mutated clone is in crosstalk with the host response to tumor, raising inflammatory stimuli leading to a prothrombotic type. And indeed, there is good data, mainly generated from studies using human cells and samples involving neutrophils, platelets, red cells, coagulation proteins, all leading to an increased propensity to blood clot activation and blood clot formation. So what is the genetic landscape, and what are the reasons why we develop diseases the way we do, or our patients develop the disease the way they do, despite having a fairly limited number of mutations? So the JAK2 V617F mutation happens at the stem cell level. Many of you would be familiar with the ARCH, age-related clonal hematopoiesis. 2 papers were published simultaneously in NEJM about just over 12 months ago. About 0.1 to 0.2% of 60+ years aged individuals were found to have the JAK2 V617F mutation. What are the factors that lead from having a clonal hematopoiesis to a proper MPN syndrome? It's now thought that one is chance, so other mutations happen and lead to transformation to a disease. The second is fate, so inherited or other genetic susceptibility, including other epigenetic mutations leading to an increased propensity for developing MPN, and a whole host of host factors which are acquired factors including age, iron deficiency and so on, which influence the expression of disease. So in a population survey in Sweden of about 50,000 patients, they found 63 with JAK2 mutated state, of whom 30 had myeloproliferative disease at the time of first analysis. 5 years later, out of these, 48 were examined at follow-up, of whom 22 had pre-existing MPN, but 18 were newly diagnosed to have MPN. And outside of the 18, the 8, one had splenomegaly without a proper MPN, and the other 7 had no MPN but a high LDH. Very intriguing data. And if you look at the graphs, this gives you an idea of how JAK2 mutation of the V617F can lead to an MPN disease phenotype. So over a period of 8 years, this is what happens to the JAK2 mutation burden in the 18 individuals who developed an MPN during the follow-up period. Above a cutoff of about 2%, they all tend to increase either gradually or quite sharply over this period. Whereas those that did not develop the MPN phenotype tend to retain their JAK2 burden at a fairly low level, although in some of them it does tend to go higher than the 2%. This graph represents what happens to our blood count. So this is red cell volume over a period of 8 years. So there's a gradual increase in the red cell mass in these patients. The corresponding graph in people who don't develop the disease, the red cell mass doesn't increase. This is platelet counts, which again, there's no sharp increase, not as sharp as it is in the red cell mass, but the platelet counts do tend to continue to be high, as do the erythropoietin and LDH levels. So what is JAK2? It's a tyrosine kinase belonging to the JAK family, so JAK1, JAK2, JAK3. It interacts with hemopoietic cytokine receptors EPO, thrombopoietin, GCSF, GM-CSF and IL-3. It stays in the cytoplasm usually. The tyrosine kinase part is labeled as a JH1 of the JAK2 gene. It's tightly controlled by its neighbor, which is the pseudokinase part called the JH2. And in fact, it's this pseudokinase part that is the mutation hotspot region, having mutations of our common JAK2 V617 on exon 14, an exon 16 for B-cell leukemia, and the other mutation for polycythemia, which is exon 12. And this is just a pictorial depiction of the JAK gene at the top row. This is the JH1, which is the kinase region, and the JH2, which is the mutational hotspot region. It's a single nucleotide substitution, G to T and valine to phenylalanine, and basically it sets off cytokine signaling downstream without the cytokine binding to the receptor. However, it does require the right receptors to allow such signaling to occur. And the consequences of excess signaling do actually imitate physiologic excess. This mutation occurs in the stem cell compartment, and interestingly, it doesn't confer any survival advantage to the cell. And competitive transplant experiments have shown that JAK2 mutated HSCs don't have a survival advantage, and leading to the question of whether this is actually a hematopoietic progenitor cell driven disease rather than a stem cell driven disease. Both knockout models and knock-in models have established that it's lethal if this gene is knocked out of an embryo, and it can produce, just introduction of a single mutation can produce an MPN phenotype. Additional mutations can predate JAK2 or can post-date JAK2, and both can modify the expression, especially the TET mutation. The activity of JAK2, why should the presence of this mutation lead to such different expressions in different individuals? How does a phenotype get determined? Possibly one reason is that the strength and the extent of binding of the JAK2, mutated JAK2 to the different receptors and the extent of the downstream effects on the JAK-STAT pathway vary from individual to individual. So the intrinsic variation of this pathway might explain the different phenotypes. Furthermore, as I previously said, extrinsic variation with inflammatory states, iron stores might also contribute to variable phenotype. So this picture by George Vassiliou shows a pictorial representation. So different time points at which the JAK2 hits hematopoiesis, leading to variable diagnosis of MPN. In some people, they don't develop MPN, but just increase the clonal hematopoiesis. I draw your attention to the bottom part of the graph, where he has also added TET2 mutation. Addition of a TET2 mutation, which is a myeloid gene activating mutation, confers a survival advantage to that clone. So if a JAK2 mutated patient develops a TET2, or if a TET2 mutated patient then gets on to have a JAK2 mutation, that clone survives and gains advantage and then manifests more easily as a myeloproliferative clone. How does JAK2 influence thrombosis? Again, these are possible theories derived from experimental data. Red cell adhesion via the Lutheran-based antigen system and its ligand on the endothelial cell has been shown to be increased in JAK2 mutated patients. Platelet hyperresponsiveness through the MPL signal transduction pathway has been established. Neutrophil and monocyte activation via tissue factor, MAPK pathway, PI3 kinase pathway have also been proven. And also possibly endothelial activation, although the data on that are still limited. This is just a picture to remind us all about the role of red blood corpuscles in thrombosis. And from 2013 data, it would seem that they have a more fundamental role even compared to platelets, which then tag on to the red cells after the first initial event of the red cell tagging on to the atherosclerotic plaque lesion. And so the role of red blood corpuscles in our blood circulation, bland as they may be, seem to have a considerable importance in MPN. Rheology, for example, the high hematocrit resulting in high viscosity, high shear rates where the platelets are pushed to periphery, so especially cerebral blood flow seems to be related to that, but low shear rates expose a rolling mechanism of red cells to endothelium, and hepatic venous occlusive diseases seem to relate more to that. So to CALR mutation, we all know, I think, that CALR mutation has an overall low thrombotic risk, but I thought it's worth just talking about it very briefly. Younger patients, more female, they're mutually exclusive, so you don't get both genes mutated in the same individual. And this picture shows you what happens with the CALR. It's always the C domain that's involved and the KDEL segment, which gets replaced either by an insertion or deletion, leading to a novel terminus. And until recently, we didn't know how CALR actually caused this myeloproliferative problem, but we now seem to know how it works. The mutated calreticulin binds to the MPL gene, and so really it requires the MPL gene. CALR mutation cannot produce a phenotype unless it has an underlying MPL gene. If you knock out the MPL, CALR doesn't affect anything. It rests in the endothelial, in the endoplasmic reticulum. It's a chaperone protein that chaperones proper binding of calcium and proper movement of calcium. When mutated CALR binds to MPL, it gets pushed out to the surface, where it then sets off the JAK2 signaling pathway aberrantly, leading to clonal hematopoiesis. And because it's MPL driven, it's just the megakaryocyte that gets affected, leading to platelet overproduction. And because it's megakaryocyte, it gives you far more in the way of reticulin, and so myelofibrotic phenotype after essential thrombocythemia. So all three genes, the JAK2, CALR, and MPL, have a common mechanism through the JAK-STAT pathway. And that's clinically exemplified by the fact that JAK2 inhibitors work in all the three mutations. So to summarize the last section with regard to the genotype-phenotype interactions, the intrinsic factors that influence how an MPN phenotype works primarily is by how these genes or these mutations relating to abnormal proteins link in with their respective receptors. Is it EPO receptor dominant or is it TPO receptor dominant? Next, what's the gene dosage of JAK2? So high signal dosage leads to a PV phenotype. Hence, exon 12 disease is just PV. You don't get any other phenotype, and that's because it's a high signaling mutation. Uniparental disomy of chromosome 9, for example, leads to loss of heterozygosity, so much more homozygosity prevalent and leads to higher polycythemic phenotype. Additional mutations which I've alluded to earlier, such as the TET mutation, can influence how the phenotype develops. The order of mutations, is it JAK first or is it TET first, also gives you an influence on the phenotype development. Extrinsic to the JAK gene is the 46.1 haplotype, which has been overrepresented in MPN patients. There are many studies that have looked at 46.1 haplotype. There isn't any compelling data to say that we should use that as a diagnostic test, but in population studies, this haplotype seems to be important in influencing disease development. And stromal-derived cytokine abnormalities, either due to independent dysregulated genes or the neoplastic cells influencing the stroma, also influences it. And so the next two slides are really the state-of-art understanding of our understanding as a hemato-oncologist in the diseases belonging to the MPN group, and how a variety of genes have led us to understand how the disease progresses and how we can think of these diseases across a spectrum as a single disease model, but with variable expression. But what's lacking in all of this is how we transpose on it the thrombotic landscape onto the myeloproliferative landscape. And so detailed analysis of genomics, epigenetics, and clinical data on how well thrombosis can be characterized across these is still a little behind. So to get on to some of the thrombotic data, there are many good RCTs, and I haven't included in these the more prominent myelofibrosis RCTs that we've had with the COMFORT studies. But the common thing across all of these RCTs for PV and ET is that vascular endpoints is a common endpoint. And for all of us who work in MPN, we use risk stratifications for thrombotic risk in ET, in PV, and myelofibrosis. And I put up this chart not to give you exactly what the risk stratification scores are, but to give you an idea of how we still don't know so much. So the pluses and parentheses are situations where we know that they matter, but actually no proper studies have addressed it yet. So for example, we all know that in ET and in PV, white count is very important. And in practice, we now start worrying about it, and patients with a high white count, we start thinking about chemotherapeutic options. But actually, none of the randomized studies have addressed white blood count as a discriminating factor in addressing whether they should be treated individually. Similarly, in myelofibrosis, there are no randomized study done to address thrombosis. Cardiovascular risk factors are considered important, but have not been addressed at all in these studies. This is a heat map, and for those of us who are used to genetic heat maps, this is a symptom heat map. And this symptom heat map is for myelofibrosis patients, basically allowing us to understand patients across different clusters of symptoms. What is interesting about this heat maps is this is very discriminating. Some patients have a whole host of symptoms related to anemia, for example. Some would have a whole host of symptoms related to fatigue, for example. None of that actually correlates well with the disease-related risk grouping, which is the IPSS score or the DIPSS score. And perhaps more importantly, none of that correlates with vascular risk in myelofibrosis. So really, we're looking at very different aspects and manifestation of the diseases in these various sections of our bodies. So what's the thrombotic risk? Polycythemia, in 2000, it was estimated to be 5.5 per patient year, although that seems to be now improving. And again, it's attributed to improved cardiovascular care in our general health systems. Recurrence of thrombosis is usually type specific, so arterial recurrence with arterial and venous to venous, but about a third would recur the other way around. ET, the risk is about 2 to 4%, and prefibrotic myelofibrosis goes along with ET. Myelofibrosis, the risk of thrombosis is about 1.75% per patient year. A database in the United States with 2,300 patients showed, of which 77% were high-risk polycythemia vera, showed that 86% had an underlying cardiovascular risk factor: hypertension, smoking, obesity, hypercholesterolemia, and diabetes. We undertook an audit in 2013 in which 40 out of 83 GPs replied. 53% of the replying GPs didn't undertake a cardiovascular risk assessment in the MPN patients in the past year. So our knowledge and our handling of cardiovascular risk factors in these patients is in clinical practice quite variable and poor. Prior thrombosis, it's a very important point, prior thrombosis, because in all the risk stratifications we use previous history of thrombosis as an important risk for future thrombosis. So what actually happens? How many patients do have prior thrombosis? So this is an interesting study from 2016. 1,000 patients, overall about 20 patients had prior thrombosis. The platelet counts weren't high, about 400 to 700. Most of them had high white count, and in those who had high white count, the prior thrombosis risk was even higher. And this is the kind of graph. So years before diagnosis, this is where they are diagnosed, and years before, -4, they have had high platelet counts. And these platelet counts haven't varied hugely over time, but during this period, about 33% have developed a clot. And so this is the primary event that has gone undetected here, but has been detected downstream. And this is a common experience for many of us in clinics, where we see somebody with a clot and then have had a blood count done. And then, so the first clot is often the initial factor, the presenting factor, but doesn't get identified as an MPN factor. So that was summarized by Schwartz, who's one of the authors in that paper, as to say that we've shown that platelet counts at diagnosis do not have a prognostic relevance in patients. This doesn't mean, however, that they're not an important predictor of thrombosis. So patients suffering from thrombosis have a higher median platelet count before the event. So what about the timing of thrombosis, therefore? If we look at all the main RCTs with quite large numbers of patients, at diagnosis, ET patients have about 30%, PV patients about 40%, myelofibrosis about 10%, and PMF more like ET patients. The majority are arterial, except in myelofibrosis, where 50-50 of prior thrombosis is venous, especially abdominal venous, raising the question of the role of spleen, for example, in the possibility of developing abdominal venous thrombosis. And follow-up clots, despite being on secondary prophylaxis, is high. So briefly about treatments, and again, I'm not going to be systematic in covering all the treatment options that patients have. JAK2 inhibitors, so we've seen how JAK2 influences both the MPN phenotype and the thrombotic phenotype, and a meta-analysis in 2016 shows that both the COMFORT trials, which is myelofibrosis, and the RESPONSE trial, which is polycythemia, showed an improved risk ratio for thrombosis in patients treated with ruxolitinib. Aspirin, the 100 milligrams a day of aspirin is the standard in Europe, 150 or 75 milligrams in the UK. And this study is one of the few that deals with aspirin sensitivity. Most of us don't think about varying doses of aspirin, and as John alluded to pharmacokinetics in hemophilia patients, it's a very interesting area of variable responses to a drug that we take for granted. 41 patients were randomly assigned to either 100 OD or 100 BD or 200 OD, and this group measured thromboxane B2 as an indicator of aspirin efficacy. Now, and what they found was that in patients with a BD dosing, the level of thromboxane B2 was consistently lower than in those who either had 200 once a day or 100 once a day. And their summary is that it's likely that MPN patients have abnormal megakaryocytes, leading to altered metabolism of the cyclooxygenase in the platelets and leading to, therefore, inadequate aspirin-related control. ACE inhibitors are an interesting idea. We know, for example, from renal transplant patients who have polycythemia after renal transplant. So about 8 to 20% of patients with renal transplant have polycythemia. And we know that in those patients, ACE inhibitors or angiotensin receptor blockade helps to reduce the hemoglobin. It also keeps the blood pressure under control. We know that hypertension is common with polycythemia vera. And we now also know in the last year or so that there is increased renin-angiotensin system upregulation and local sympathetic nervous system upregulation in the bone marrow niches in MPN patients. Given all that, the ECLAP database of 1600 PV patients were reanalyzed, and it was found that patients on ACE inhibitors required less cytoreduction to maintain a stable hematocrit. So controlling the renin-angiotensin system improves the blood pressure, improves the drive to increased hematopoiesis, and controls the hematocrit. So this is a very novel approach to non-chemotherapeutic control of polycythemia, hyperviscosity, and stroke risk. Recurrence on vitamin K antagonists. The recent ACCP guidance on anticoagulation for MPN patients who experience venous thrombosis recommends long-term anticoagulation. In terms of a 2016 study of 430 patients, including many with SVT, splanchnic vein thrombosis, and some with cerebral vein thrombosis, the recurrence rate was about 4.7% on vitamin K antagonist and 8.9% off vitamin K antagonist. And 20% of the recurrences were arterial, the rest were venous. So that, despite being on vitamin K antagonists, there's still a high recurrence rate. The bleeding risk is 2.8% when both aspirin and VKA are used versus 0.9% when only one of them is used. With regard to pregnancy, there is now good data to suggest that pregnant women having ET are at relatively low risk for thrombosis-related complications. Preeclampsia and abruption are one group of problems that they might experience, but the recommendations in 2017 are antepartum vigilance with or without low molecular weight heparin, depending on other risks, and as Aggie Lee said, on patient preferences, and postpartum standard low molecular weight heparin. Now for a few brief slides on one of my specialties of interest, which is abdominal vein thrombosis in MPN patients. I'm just going to give you a brief history of 3 patients. This is a 68-year-old PhD student who was diagnosed to have myelofibrosis. And so he had myelofibrosis diagnosed when he was 59. He has a CALR mutation, and in 2012, so about 10 years after the diagnosis, he has a splenic infarct. Platelets were normal at that time. A year after, he has myocardial infarction with CABG, left ventricular thrombus, PE, a stroke, a popliteal embolus, all in that one episode. So he was on aspirin and warfarin, and when these took over his life, we started him on ruxolitinib. So the interesting points about him are that he's CALR mutated, typically thought to be low risk, multiple arterial thrombosis, and again, true to the point that arterial thrombosis recur with arterial thrombosis. He has a PE, but more in the context of an LV thrombus. His spleen has responded to ruxolitinib, and he remains symptom-free and thrombosis-free. This is a 66-year-old vicar who has a post-ET MF diagnosed with 2013 with a JAK2 mutation. He has a sagittal sinus thrombosis at the time of the diagnosis. In fact, the diagnosis was made after the thrombosis. He then has, the following year, mesenteric and portal vein thrombosis. He then has a PE, all of them on warfarin. He continues on warfarin at a higher dose, and he was started on ruxolitinib with the diagnosis of myelofibrosis. The points about him are he's had recurrence at 3 distinct sites despite warfarin. He's had no arterial event, and the spleen response to ruxolitinib has been impressive in him. And after starting ruxolitinib, we haven't noticed any further vascular events. 65-year-old golfer, again in 2011, he has a normal blood count but found to have a splenomegaly. Investigations for that shows that he has extramedullary hemopoiesis in the liver. That's how the diagnosis was made of myelofibrosis. He has a splenic vein thrombus, portal hypertension, and varices. His DIP score is low, but he's had a DVT, warfarin, recurrent DVT on warfarin, a further PE on warfarin. Started on ruxolitinib, remains on warfarin, and remains stable. So Lisa Pieri in Vanucci's group in Italy has studied 21 patients of SVT with ruxolitinib, and they have found that 30% of patients, the spleen size goes down on MRI, and 60% the spleen size reduces by palpation. There's no impact on varices. Some of you may remember that in an NEJM paper by Kalajian previously, by American authors previously showed that varices have also gone down on ruxolitinib. So in my clinic, we have a total of about 400 SVT patients, which the hepatologists look after. But if you take away the cancer, cirrhosis, transplant, pancreatitis, there are about 41 NPN and notably 7 JAK2 alone with normal counts. So it's quite a substantial number. And the disease burden is high. This is the status of all patients. The blue represents the number dead. A number alive. The status of SVT patients with hematologic diagnosis, many more are alive, but even so about 11% have died. So MPN related SVT in the acute setting can be fatal. In the chronic setting is plagued with a huge disease burden. And for this group of patients, we have a dedicated service where we run a polyclinic, and we are developing an app to try and help these patients navigate their disease and come to terms with the information about it and to document their symptoms. So in summary, JAK2 mutation drives the MPN clone and also confers a thrombotic risk. The influencing factors for thrombosis is only partly characterized. Distinctive thrombotic syndromes remain unexplained. Why, for example, should SVT be more common in JAK2 patients? Risk of primary event and recurrence remain high despite warfarin. Long-term warfarin is beneficial for MPN-related venous thrombosis. JAK2 inhibition is beneficial in thrombosis, and there have been no formal studies using DOACs. And all of these raise the need for groups such as this and consortial approach to management of this disease across the oncology consortia and the hemostasis consortia. Thank you very much.